Okay, Dr. Rahul, we are live. We can begin.
Okay. Hello, everyone. I am Dr. Rahul Mandlik, heading Medical Affairs at Shalina Healthcare, Dubai. On behalf of entire Shalina Healthcare, I would like to welcome all of you to this panel discussion, where we have wonderful spectrum of panelists over here to share their perspectives on malaria elimination. Very briefly, Shalina Healthcare is one of the largest pharmaceutical companies in sub-Sahara Africa, and from last 35 years, it is our mission of making quality medicinal products and also to make them available across Africa at affordable rates. Today, we are marketing more than 350 products spanning across 12 therapeutic areas, and we manufacture these products in our own WHO quality approved manufacturing facility, and we get some of these products outsourced from other WHO approved facilities. At Shalina Healthcare, we strongly believe in improving quality of healthcare in Africa. And with this thought, we have been continuously delivering online as well as offline educational programs for our healthcare professionals. And trust me, going forward, these educational activities are going to be more exciting under this banner, which you can see on the screen. That is Shalina Professional Engagement and Education, and the acronym for which we have coined is SPEED. So under SPEED program, you will see many educational activities happening. Well, now let me welcome our wonderful and amazing panel members from the academic and government sectors who will be talking on malaria elimination, current status, challenges, and strategies. All right, the format of the program is like this, that every panel member will talk for about 15 minutes, and once they have spoken, uh, followed by that, I will open the house for question and answer discussion. And if you have any questions while attending this webinar, please feel free to post them on the box provided on the right side of the screen. Now, I would like to introduce this eminent panel to you, starting with Professor S.K. Ghosh. Professor Ghosh is former head of ICMR-National Institute of Malaria Research, Bangalore, India. Currently, he is a member of Scientific Program Committee at American Society for Tropical Medicine and Hygiene. He is also a visiting scientist at Tata Institute for Genetics and Society in India, and he is associated with many universities like NITTE University, Mangalore University, and Manipal University in India. He has got around 40 years of experience in malaria and other vector-borne diseases, and Professor Ghosh has developed a point-of-care micro-PCR device for malaria diagnosis, and also he has developed tab-based digital surveillance. Professor Ghosh is actively involved in community engagement programs, and one of his pet projects is the use of repurposed larvivorous fish in malaria control. So he has also worked and developed many vector control methods, and he has published 120 papers in reputed and peer-reviewed journals. In 2019, Professor Ghosh has been awarded with Sri Vivek Singhal Memorial Award for his contribution in this area of malaria. Well, moving to next speaker is Professor Mokuolu. Professor Mokuolu is currently associated with the Department of Pediatrics and Child Health at University of Ilorin Teaching Hospital, Nigeria. He is Malaria Technical Director at National Malaria Elimination Program in Nigeria, and he has got over 25 years of experience in clinical, academic, and programmatic issues in malaria, neonatology, and public health. Professor Mokuolu has chaired from 2017 to 2019 the Technical Expert Group on WHO Anti-Malaria Treatment Guideline, which is released by WHO, and he also facilitated the release of over $2 billion in support to many African countries for their fights against malaria. He has directed the national and zonal TOT on malaria case management, producing over more than 1,300 trainers in Nigeria. He has published 90 papers in peer-reviewed journals. In 2011, he was listed in United Nations New York Photo Exhibition of Champion to End Malaria. He has been awarded with first runner-up in British Medical Journal Organized Awards for the Best Research Publication for 2010, and he is a joint winner of 2017 NLNG Prize for Science in Nigeria. Moving on to next panel member, Dr. Ayongo Annan. Madam is family physician specialist at Korlebu Teaching Hospital, Accra, Ghana. She is a member of West African College of Physicians, and currently she is president-elect of Medical Women Association of Ghana, Greater Accra branch. And right now she is serving as a vice president at Society of Family Physicians of Ghana. She has got 16 years of experience of clinical practice and health education, and she is a certified healthcare professional in health administration and management. Dr. Annan is very active preventive health advocate, at the same time one of the doctors in charge of the women's clinic at Polyclinic Family Medicine Department at KBTS Accra. So to begin with, first I will invite Professor Ghosh for the first topic, and Professor Ghosh is going to talk about the currently available treatment options, the challenges which we are facing in the management of malaria, and future developments. Over to you, Professor.
Thank you, Dr. Rahul, for your nice introduction to all the speakers. And I request Hitesh to show my slide. Rahul, Hitesh is...
Yeah, Hitesh, can you hear us?
Yes.
It is coming up, sir.
Yes. So I will talk on recent advances in malaria treatment, research, and elimination challenges and hope, because now there are many operational research and a lot of research going on malaria, and we definitely hope to have malaria elimination, because malaria elimination is the buzzword, and definitely many countries, they have eliminated malaria in the few years. So now I'll talk on the countries which is still facing problems, especially in sub-Saharan African countries. Hitesh, next. So in the overview, I'll just go some introduction, then antimalarial drugs, treatment schedule, new avenues, challenges for malaria elimination, and the way forward. That is the thing I want to discuss today's panel discussion. Next. So you know all that malaria is a word from medieval Italian word, means bad air, malaria. It is very known since 600 to 5500 BC. In our Indian Vedic writings, 1600 BC, it is mentioned. Hippocrates mentioned almost 2500 years ago. In Indian Ayurveda also mentioned about its association with mosquito bite. Next. If you see that first malaria parasite was recognized by Charles Alphonse Leverin in 1880, and it was an Arnstein's smear in Algerian patients. Then 1897, you all know, Ronald Ross discovered in India, in Secunderabad, and he got the Nobel Prize. You all know, till now, there are 5 Nobel laureates in malaria, and the last one was 2UU for the discovery of artemisinin, and the Nobel Committee recognized that this is the only drug which is hopeful for malaria control and elimination and treatment. So it is a protozoa group, and you know that it is hemosporidians, means heme means blood, infecting parasites. There are now 5 human malaria parasite species: Plasmodium vivax, Plasmodium falciparum, Plasmodium knowlesi, Plasmodium malariae, and Plasmodium ovale. So knowlesi is basically monkey malaria. It is present in the Malaysian area in the forest zones. So now it is also recognized as the 5th human malaria parasite. Next. So there are almost 3 billion, half of the population in the world is, and over 90 countries under risk. If you talk of clinical plus, confirmed malaria, there are 300 to 500, and now there are about more than 4.4 million cases of malaria deaths in 2018. 90% cases are reported from Sub-Saharan Africa and 10% rest of the world. And India contributes 87% of malaria in Southeast Asian countries. Next. Now we see the life cycle. So life cycle, if you want to see the life cycle, it starts from the mosquito bites. The mosquito contains the sporozoite of the parasite, and then it goes to the liver. From liver, it goes to the blood. That is called erythrocytic stages. So in the liver stage is very important because in case of vivax and ovuli, they are called hypnozoites. So these hypnozoites actually cause the relapse. So this is a challenge now because there are few drugs for anti-relapse. And then in the blood stage, the sexual stages are formed. And at this stage, it takes about 10 to 12 days in case of falciparum, but in case of vivax, it develops simultaneously very fast along with other stages of malaria. And then when this gametocyte stage is formed, the fresh mosquito bites, and from this bite in the mosquito cycle, it takes about again 10 to 12 days, it produces the sporozoites. And this is the way the life cycle completes. Why I'm describing this life cycle? Because it is very important to know which are the drugs are effective. Most of the drugs are schizontocidal drug, means they are effective against the blood stage of parasite. And there are very few drugs are anti-gametocide, but there's no drug anti-sporozoite. There is only drug which I will describe next, which is primaquine and tefenoquine for the hypnozoites. Next. So if you see the classification of anti-malaria drugs, there are, I have mentioned 4-aminoquinine, quinoline methanol, then Syncona, because the first drug was quinine, and from them all these drugs have come. Biguanide, proguanil was using in the 1960s, diaminopyrimidine, 8-aminoquinine, it is a primaquine, and now tefenoquine is under development. I think it is very on the stage of coming in the program. Sulfonamides, sulfur drugs, mostly, which is dapsone, especially is treatment for many other antibiotic also, and leprosy also. So it is used in malaria treatment. Antibiotics also are being used, tetracycline, doxycycline, clindamycin. And the most important is that sesquiterpene lactone, which is actually artesunate, and this is the drug which was discovered by Tutu and then got Nobel Prize, I mentioned. Amino alcohols, that is halofantine and lumefantrine. So this amino alcohols, lumefantrine, is in combination with ACT. That is called artemisinin combination therapy. And then nafthopyridine is the pyridine. Pyridine is a drug with artesunate, and I have done the trial in India, in Mangalore, and it is not yet come in the market. I think this registration is due and going on. So it will very soon come in the market. And then naphthoquinone, that is atovaquone. Atovaquone was the drug which is actually used, but resistance came very fast, so it is not come in the use now. Next. So if you see what are the available drugs, I can tell you for Vivax, chloroquine is still sensitive, except 10 countries, because now many countries in Africa, this Vivax is now reported. And artemisinin-based combination, if it is not sensitive. In India and many countries, they are using still chloroquine, and we are very comfortable in India because India contributes about 50% of total Vivax burden in the world right now. Falciparum malaria, you all know it is the dangerous malaria. There is a malignant malaria, and then no more chloroquine is recommended anywhere parts in the world. And chloroquine resistance, I have given a series of ACT combinations, artesunate sulfodoxine pyrimethamine, which is in India. And India, mostly other drug or artesunate lumefantrine, these two drugs are used. In African countries, I think, lumefantrine and artemether lumefantrine and I think DHA piperquine or mefloquine, these are the drugs are being used. And then atenolol piperacin drug, which has been manufactured in India by Sun Pharma, and I was the investigator for clinical trials, and it is very effective. And the drug, how it came, I'll say the next slide. Basically, artemisinin, it is Artemisia annua, the sweet worm, and then there is a project called 523. It was done by U2 in Vietnam, and they found it's very effective, and that thing came in the light in 1975, and then the rest is the history. So primaquine is not recommended for pregnant women and infants, because this is feed deficiency problem. So anyway, this drug has to be administered 14 days in case of Vivax, and single dose for falciparum. And GCSPD test must be done before administering this particular primaquine. Tefenoquine also has to be done. So tefenoquine, one problem, single dose, but the only problem that half-life is very high. So if any GCSPD deficient problem comes, it has to be taken very carefully. So under medical supervision. Again, next. So I have given a platform of new drug. This is under MMV, Geneva-based organization, not for profit organizations, and they are having a lot of drug, in the baskets molecules, and they have some trial going on. The three drugs, I think KA609 and M5717 and KAF156, which is, I think, Novartis, they are now with MMV trial is going on. I think it is very soon be in the Vietnam, and I think some other country, they have done the trial, and the trial is showing very, promising. Next. So in our study, I have mentioned that pre-Vivac liver stage, and you can see that in the fast, you can see that there is same type, the very minute green color, you can see fluorescence color, that is the hypnozoite. And we found 2 molecules from MB was hitting. This is a proof of concept study, and it is published in Malaria Journal, 22nd of June. And I think we have to give a forward for this particular drug to for anti-relapse anywhere, and we'll start from India. Next. I can tell you that now you can see the picture is very almost all the tropical countries is full of malaria, and China, of course, for last 3 years there is no case reported. Sri Lanka, they have I think right now there are about 35 countries they have eliminated malaria, and they are under the vigilance phase. I mean, Sri Lanka also, they are now done it. So China, if they do it this year also, they will get the certification. So that way it is getting ready. So this is picture, and then is I'll tell next. So I think the problem is now the synthetic pyrethroid, which is actually the main weapon for vector control, and this resistance is very, very disturbing, because in Africa, this major vector Anopheles gambiae, they are getting resistance in, and also in India, synthetic pyrethroid resistance have started. We have, I have done it in Karnataka in India, and it is a disturbing factor. And also artemisinin resistance in Greater Mekong region. So that is another challenge we have to face for elimination program. Next. Now we can see this slide that there was a decline of malaria cases in 2015. It was very encouraging because a lot of efforts made throughout, and the major emphasis was on long-lasting insecticide-treated nets with synthetic pyrethroids. And I have shown the slide that pyrethroid getting resistance. Again, there is artemisinin-based combination therapy to most of the endemic countries. And now we can see that high burden and high impact, what WHO says now is, these are the cycle. You can see the right side, and India is also one of the countries, high burden countries, malaria, and there are 19 African countries contribute over 85% of the global burden. So India also now on the high burden. Some of the states in India, not all the states. Now India malaria declining, but the 4 or 5 tribal districts in country, so that we have taken care now. Next. Now, if you can see the target, that global technical strategies for malaria, you can see by 2030 we have to eliminate malaria, and many countries on the progress on this. So this is the goal from WHO, and we have to follow the thing right now. Next. So there are three pillars, very important global technical strategy. Pillar 1 is the ensure universal access to malaria prevention, diagnosis, and treatment. Pillar 2 is that accelerate the effort towards elimination and attainment of malaria-free status. That means those who are eliminated, we have to maintain the status. And pillar 3 is the transform malaria surveillance into the core intervention. So surveillance, they are giving the main emphasis, and all the countries say they have eliminated malaria because of surveillance and quick response. These are the buzzword, and I think we have to follow these three pillared strategies, and we will definitely achieve the goal of eliminating malaria. Next. So what is the challenge now? So I am just mentioned few points. That Plasmodium vivax, you all know it is a benign malaria, but for me it is not, because it is more complex. As far genome analysis is concerned, there is a published paper in Nature Medicine 2012, I think. It has mentioned that it is more complex than falciparum, and it is reported many parts from African countries, even Duffy negative cases. Falciparum is showing resistant to artemisinin combination therapy, and that is an K13, the KILCH13 particular gene mutations are occurring, and there are many haplotypes. And diagnosis is getting more complicated due to the deletion of PF-HRP2. HRP2 histidine-rich protein is the main protein molecule, is the probe being used, and that is the gene deletion is happening. Invasion of new vector species in the area like Anopheles stephensa in Africa and elsewhere like Sri Lanka. Vector mosquitoes are migrating at faster pace. In a Nature publication last year, we found in a single night of 9 hours, sub-Saharan Africa, a mosquito can travel up to 300 kilometers and at a height of 295 meters. I think it is a news for everybody. So, and they have done genome analysis, and all the mosquitoes are same genome footprint. So that means they are migrating from one to one country. So it actually challenge. Then vector mosquitoes are showing resistance. Now, if you add, piperonil butoxide, that's PBO. It actually, it reverses the process, and then it shows resistance susceptible, but the cost become double. So another problem. Again, the community engagement is a thing. Shortages of skilled human resources. I think that is another problem, that skilled manpower is not been there much in the program. And now in the COVID-19, which is now throughout the world, it is a pandemic. And then this is another problem now facing, and WHO is giving emphasis that all the ongoing program, vector control and malaria, it should continue, even though COVID threat also there. Next. So now the things that this slide I am showing you because of this, falciparum, and they were there, and now you can see that still it is not much declining. Next. Similarly, vivax, it is vivax and it is falciparum. We can see somehow little bit declining is coming, but still we have to go a long way. Next. Now some futuristic promises, the thing is that triple artemisinin based combination therapies, TACs, which you call now, that is DHA piperquine and mefloquine, one combination, because piperquine is also 4-aminochlorine, another 4-aminochlorine mefloquine is given, then artemether lumefantrine plus amidoquine. So in Lancet paper 2019, I think 8 countries they have trial. We have about 1,000 participants, and it is showing good results. I think it can go in African countries with this, safety issues. Then mass drug administrations, I tell you, you can see this American Journal of Tropical Medicine Hygiene this month issue. You can go there and you can find the DHA piperquine 4 rounds in Zambia. It is showing very good results. Almost there are 72% reduction in malaria cases, and especially in children. I think it is a very good sign. And then diagnosis, in case of diagnosis is a challenge. Now, aptamia based means oligonucleotide nucleic acid based diagnosis, which I mentioned, micro PCR based and all this. And then Gazelle one device is made which actually detects the hemojoin pigments through magneto-optical detection system and hemojoin crystals. These are the promising, and all the parasites can be, there's a paper published from India, they have shown. And now also you can see another article has come in Transaction Royal Society of ivermectin in malaria control. Ivermectin, basically it is antiparasitic drug for which the same year 2015 the scientists got Nobel Prize, and it is usually for anti-fallider drug and schistosomia and all, but is being used for malaria control now. And then sugar bait means if sugar bait is given around with ivermectin in that, then the mosquito will kill. Bush cutting around the houses also reduces malaria transmission. Now patient is tracking is important, and then that mobile tracking. Right side you can see there is one plant I just recently got, that is called Telphyria accidentalis. It is actually called flute pumpkin in African countries. It is, and it's for anemia management. I think these are the things if we can use. I think anemia in Africa is a big challenge where Dr. Mokuolu is discuss the next speaker. Next. And then some of the things, the vaccine has now come. Then drone vaccine, again, I'm telling you that it is only for children, and the protection rate might be about 30 to 40%, but still we think that if we give vaccine, the mortality, if it is the mortality, I think not the disease, I think that will be a great thing for children in Africa. And then now there are drone testing is going on in Kenya, and I think Tanzania in the rice field. If you have a spray on anti-larval, I think now we have to see it from adult to the larval stages, and then it will be very effective for this thing. Next. Some of the promising things now coming. And gene drive technology, again, it is a very good technology, but the thing is, it is again the proof of concept. It is in Burkina Faso from University of California. They are trying hard that mosquito, because the only issue that it doesn't follow the Mendelian principle, and it follows only the gene drive principle. So all the genes which has been transferred, all the mosquito will be with that gene, and that is the only thing. It is thinking of regulatory issues, but right now the technology is very robust and can be useful in malaria control. A new medication, tefenoquine, you can see from GSK, another thing they have done. I think very soon it is coming in the market for the Vivax hypnozoite challenge. Next. So this is my thing. I can tell you my share how we did it in India, in Karnataka, which was the most endemic state in the country. Now it is on the elimination phase of malaria. I came here in 1995, 96, and since then malaria has been declining and shrinking. The first thing that you have to have a dialogue with the state health department, because health is a state subject. So, and then district level, then community level. So if you have to engage in the community, you have to act. You can see me in with the community leader and telling them how to do this. And only thing that we scientists and our health professionals, we must tell the community what the path we should follow, and that way they follow and they get the result. Wonderful experience in this way. Next. So this is the tab I was talking, where Dr. Rahul has introduced. The indigenous developed GIS tab is wonderful. Just 7 July, again, we have published another additional paper. It is a wonderful method. It is given to the health workers, and then when they open the case, until they close the case, it is showing it is not closed. That is one tracking mechanism is there, and all are digitized. One button you click, you will get all the informations day by day, and then you can take the action immediately. Next. So now we have given some article. You can go through details of malaria elimination, and there are 2 articles. The one is Malaria Elimination India, the way forward, and the new ways to tackle malaria in Intecofen. I've given DOI number. You can see the article. I have given everywhere, given everything details. What are the pros and cons for malaria elimination is important. Next. This is the point of care I was talking, that this TrueNet method, it is a point of care device, and the point this is the one good thing in this, that you can also assess the parasitemia side by side. It is a real-time PCR method, and then you can have the data can be shared from your device, like mobile device, PDA system, and anywhere you want to share the thing, that can be done. And in COVID-19, this SARS-CoV-2, this same device is being used in the point of care, the same thing, and this is the thing is very effective, and it can detect almost 2 parasites per microliter. I think that is more sufficient to know asymptomatic cases also. Next. So all these things I'm showing how community engagement, it is a folk theater, and then it can go in the community in a big way. Next. You can see, in the field, and my pet program was live fish use in malaria control, and it is so effective, and vector and control monitoring and everything done. Very, very effective method. We can implement in other countries, if possible in Africa. If you need my help, I will be there. It is my expertise. I know what are the things to be done in a great way. Next. You can see the momentum. It has gained a big momentum in Karnataka. You can see the children and the people and the school and all are engaged in this program, and it has become a really momentum. And then that's what the disease is not there. Even in COVID, other states, they are showing some increase in malaria, but not in Karnataka. It is declining because of every district they have got the vector control team, and they are very, very active and under my guidance. Next. People are using this fish for their water storing tanks, because Aedes mosquitoes, they also to be controlled. And you can see the community, they are doing this. We are not doing, the community is doing. That is the main part thing. When that starts, if you see the community is coming forward, they're doing of their own. I think then it is left to the community. They will do it, and then rest will be the assured. Next. You can see the impact. Now, this is the area, almost 1.2 million population. Initially, we tried with all insecticide. Now, 2001, we got a project from WHO. We showed them how it is done, and we can see there is no malaria in these 44 primary health centers. It's not a small thing. And now this has been implemented entire Karnataka, and then the same story is coming everywhere. Next. So this is the plan for Karnataka by 2020, but mostly 2025 we are thinking to be eliminated, but still we are giving 2 years gap so that we can get 2030 for the aim. Next. You can see another thing I tell you, that workshops and training is very, very important for human resource development. And I was the local organizer for this regional entomology workshop in Southeast Asian WHO countries. And you can see it is very good impact came, and the entomological part we have to be strengthened, because vector control is the key bars. Whatever you do, vector control is a must, and that this workshop has pointed out. Next. So this malaria elimination, it is there. I am sitting on the very right side, blue shirt, and it was you can see the Soumya Saminathan. She was the Director General ICMR. Now she is Chief Scientist in WHO in headquarters Geneva. The regional director, all countries they came, and this was in 2016. Next. So now the thing suggested for elimination: the smart digital surveillance, point of care, mass drug administration, limited areas. Now showing the results in Lancet paper. Shifting of adult control to the harbor source management. This is the thing, because now COVID is coming. The mosquito nets will be multiplied, because if you cannot share the same mosquito net if anybody in the family have COVID, or vice versa, whatever may be the situations. Effective community participation, training and workshop I have mentioned, and stakeholder engagement and policy decisions. These are the few points I think it will be escalating the malaria elimination process. Next. This is the thing. I think we hope that if goes everything, then we'll definitely eliminate malaria by 2040, not 2030, but 2040. Next. Yeah. So thank you very much, and I thank Dr. Rahul, their team, and entire for supporting this program, and also Doc Mode for they are organizing this thing and giving me this opportunity. I think everybody will be gaining from my talk, and if anyone helps my my help, personal help or anything, I'll be happy to do so.
Thank you so much, Professor Ghosh. Yeah, I know it is very difficult to put all the developments in short time span, such a short presentation, and it is so remarkable. And I can see here you have put all this thing in quadrant of 2 by 2, covering the current treatment available, challenges, and the importance of community engagement and future development from new drugs to vaccine. Wonderful. So with this, we'll move to the next topic, which is related to one of the post-malaria complications, and that is nothing but the post-malaria anemia, which is commonly seen in Africa, which is widely prevalent in Africa, and at the same time, it is not, in my opinion, it is most neglected complication of malaria. So with this, I request Professor Mokolu to please share some light upon post-malaria anemia management, as well as your insights and suggestion for the management of malaria in COVID-19 perspective. Over to Professor Mokolu, please.
Thank you very much. So I'll be speaking to us about post-treatment malaria anemia and some mention of keeping up with malaria control in the midst of COVID-19 response. I have no conflict of interest to declare, so I have no conflict in making this presentation. So basically, we've taken the first presentation. Malaria remains a major public health disease, causing about 222 million cases and 405,000 deaths globally, as reported by the World Malaria Report. And the relationship of malaria and anemia is influenced by malaria and age of the subjects. From this chart, you can see, depending on the endemicity of malaria, the susceptible age for severe anemia, which are the curves that are in red. So in areas where malaria is very endemic, holoendemic, hyperendemic, you see that severe anemia occurs in association with malaria more within the children age 0 to 5 years, thereabout, okay? But in areas that are low transmission, you tend to have malaria anemia occurring across all age groups. So when it comes to malaria and anemia, there is an intricate relationship with malaria causing anemia pre, during, and post-treatment on the indices of malaria-related anemia. And I'll be sharing with us essentially many of these indices of anemia measurement in the management of malaria. For our definition, anemia is a condition in which the number of red blood cells and consequently the amount of oxygen that they are able to carry is insufficient to meet the body's physiological needs. It's classified into mild when the total hemoglobin concentration is less than or equal to 11 grams per DL, moderate, the range below 8 grams per DL, and then severe anemia when it is less than 5 grams per DL. In some other literature, 7 grams per DL is used as the cutoff, but in children, less than 5 grams per DL. So for different age groups, this particular table shows us the classification of anemia, just to say that it's important that ranges are available within local environments, and the interpretation of anemia is subject to age and subject to the gender for pregnant women or for men or children of different age groups. So we look at the prevalence of malaria-associated anemia. From the World Malaria Report 2019, between 2015 and 2018, showed that the occurrence of any anemia was 61% in African countries, sub-Saharan Africa, and mild anemia was 25%, moderate anemia was 33%, and severe anemia was 3%. But when you disaggregate the data by the positivity rate, so to the right of this chart, let's see, I'm trying to, okay. So to the right of this chart, you can see that we have the overall on the left for situations that are positive for malaria on RDT, the proportion of people who have anemia is over 80%. And when you come to the right, you see that the proportion of people who have anemia is about 60%. But more importantly, the proportion with severe to moderate anemia is over 60% in those that are malaria positive, and it's less than about 30% in those that are malaria negative, showing clearly that there is a relationship between malaria positivity and the occurrence of anemia. We recognize that there are many other things that causes anemia, but malaria uniquely contributes to anemia occurring. And this finding is consistent across several sub-Saharan African countries where it was measured. So where it was mentioned, so you can see on this side, these are countries showing the contribution of malaria to anemia, okay, in those that are positive, and on the left is those that are negative for malaria. And across board, if you look at this lower pool of the chart, all of them have very high occurrence of severe malaria being severe anemia being contributed to the anemia, whereas in those that are malaria negative, you can see that the occurrence of severe malaria, the very dark blue, is limited. So one of the key issues that have arisen over time is concern about the role of ACTs in the treatment of malaria in terms of possible effect on causing anemia. It is the most efficacious drug and remains the most efficacious drug for the treatment of uncomplicated malaria, and that is what is recommended in areas where you have P. falciparum malaria. And the use of ACTs has been on for maybe close to about 15 years now, depending on the time when countries adopted the ACT. But it's important to continue to analyze the various indices that can help us to understand anemia in the context of malaria treatment. And so I'll be taking us through a series of indices that are used to evaluate malaria-associated anemia in the next series of slides. So grouping these indices together, there are those that measure the direct effects of the disease. There are those that measure what we can call impact of the drug on the occurrence of anemia. And then there are measurements that are basically time related in terms of their definitions. So the first is the malaria attributable for in hematocrit. So this is the difference between a patient's maximum hematocrit value measured on days 28 to 42 and that on compared to that on day 0. So you have a day 0 pre-treatment hematocrit, and then the highest point of hematocrit anytime in the course of day 28 to 42. That difference, that fall, is what is called the mean attributable fall in hematocrit. It's usually considered significant if it is greater than 4%. And in our series, we discovered that it was higher in the anemic patients, okay, compared to those who were non-anemic. All right, so preceding malaria, the mean malaria attributable fall can be seen that it's higher in anemic patients than non-anemic when you are managing malaria. So just illustrating it from the point of this table, okay? So we see the malaria attributable fall, so in hematocrit. So that's the difference between the hematocrit on day 1 and then the highest point of the hematocrit before day 42. And that difference is the mean attributable fall in hematocrit. Then we have the total malaria attributable fall in hematocrit. That is the difference between the patient's maximum hematocrit on days 28 to 42 and the lowest hematocrit value recorded in the first week post-treatment initiation. So the difference here is that you will notice that shortly after day 0, there is often a fall in hematocrit value. So that lowest point of that fall and the difference of the highest point in day 28 to day 42 is what is known as the total malaria attributable fall in hematocrit. It helps to estimate total erythrocyte loss, and recovery from this is delayed when we have failing treatment. And this is an evidence that shows that using an inappropriate treatment like monotherapies for management of uncomplicated malaria in falciparum-dominated areas is very disadvantageous. Then we have the drug attributable fall in hematocrit. And basically, this is the difference between the malaria attributable fall in hematocrit and the total malaria attributable fall in hematocrit. In other words, the difference between pre-treatment hematocrit and the lowest hematocrit recorded in the first week. So day 0 hematocrit, that's pre-treatment hematocrit, and then the lowest hematocrit within the first 7 days. The difference in that value is what is called the drug attributable fall. Again, it is considered significant if greater than 4%. And overall, it tends to be higher in non-anemic compared to anemic children, that is those who are anemic at onset compared to non-anemic children. So it tends to be higher in non-anemic children compared to anemic children due to their relative lack of conservation. What we are saying here is that those who are already anemic, it goes by the saying, he that is down needs fear no fall. They are already sort of down, and so their own further reduction is minimized in the first week of treatment. And so you can see this chart illustrating, without going into too much of the specifics, you will see that for the anemic children, this fall, most of these lines that are representing the changes are nearly horizontal, okay? But you can see the greater gradient of this line in those who are non-anemic, showing that the magnitude of fall was much on this side compared to those who are anemic at presentation. So malaria attributable fall is higher in those who are drug attributable fall is higher in those who are non-anemic at presentation compared to those who are anemic. Then very common, a concept that emerged and which threatened our current approach to management of malaria, especially severe malaria, is the reported post-artesunate delayed hemolysis. Essentially, this is characterized by greater than a 10% decline in hemoglobin levels, occurring more than 1 week after treatment initiation. So the initial series were reported in travelers who were returning into countries that are malaria-free, and this brought about some initial caution to watch out carefully the use of injection artesunate. But haven't had very large multicenter studies, and then going on to specifically, systematically study this concept among African children, it was clear that this concept of post-artesunate delayed hemolysis is very rare in African children, and hence it should not bring about any concerns in the treatment of severe malaria using injection artesunate. So for the studies conducted by Fanilo et al., all the parameters that will have suggested hemolysis were examined. Here on this chart, you could see the red line for quinine and then the green line for artesunate. And you can see the trend in hemoglobin concentration following treatment. It is comparable for the two drugs. There is no difference, even up to 6 weeks after follow-up. And the once infected red blood cells, you can see that after the initial peak of that, there is a gradual fall for that. So it's not showing any activity going forward. And it's similar to quinine treatment by the end of 4 weeks of observation. Reticulocytosis, which will have been an evidence of ongoing hemolysis, that is visible at the early stage of treatment, but you will see that with progression in treatment, again, reticulocyte count goes progressively lower, showing that there is no reactivation of a hemolytic process that is going on. And similar for plasma LDH, lactate dehydrogenase. So all the evidence that will have shown active hemolysis reoccurring after an initial recovery, there is nothing in all of these parameters that assess hemolysis that was shown to be abnormal, and it's consistent with the behavior of quinine or quinine. So the conclusion was that severe delayed hemolytic anemia is rare in the population of African children with high parasitemia. This reassuring evidence contrasts with early reports among travelers as far as African children are concerned, and it strongly supports the wider deployment of life-saving parenteral artesunate for the treatment of severe falciparum in African children. Now, based on temporal classification, time-related classification, there are additional indices of that is used to measure anemia in the context of malaria treatment. So we have here the first, early appearing anemia. And this is treatment-associated anemia in children who were not anemic before treatment initiation. There is the deficit in hematocrit from baseline. So they were not originally anemic, but then you see that anemia occurring after initiation of treatment. And in a multivariate analysis, an average age less than 15 months, less than or equal to 35, were independent predictors of progression to anemia within the first week of life. So on a temporal basis, we have this classification. And here we are in our own study, we found this association of this anemia, and you can see that as the age was increasing up to 36 months, the proportion of occurrence of early appearing anemia was increasing. So if you divide the study population into two, less than 36 weeks and greater than 36 weeks, we have this early occurring anemia occurring more frequently in those less than 36 weeks of age. Then we have the persistent early appearing anemia. This is hematocrit less than 30 within 2 days of treatment initiation in a patient who was not anemic at presentation and persistent for at least 7 days in the absence of any concomitant illness. And if this is not, sometimes this can progress into what is called late anemia, late appearing anemia. So the third category on a temporal basis is late appearing anemia. So don't forget early appearing anemia, persistent early appearing anemia, and then late appearing anemia. The criteria here is that there has to be an adequate clinical and parasitological response occurring within 1 week, hematocrit greater than 30%, or at 1 or 2 weeks. A fall in hematocrit to less than 30 occurring at 3 to 6 weeks, absence of concomitant illness at 1 to 6 weeks, and absence of asexual parasitemia by both microscopy and PCR at 6 weeks. So this is a slightly more delayed anemia that is occurring after initial adequate clinical and parasitological response. And the last category with respect to time is the time that it then takes to recover from the anemia, which is called the anemia recovery time. In patients who had had persistent early appearing anemia or late appearing anemia, anemia recovery time was defined as the time from appearance of that anemia to the recovery from the anemia. So we see that there are several concepts that are used to measure anemia. Now, to the causes of this anemia, on a general sense, there are many things that could cause anemia outside malaria. And I will not be discussing that today, but just to mention that iron deficiency is one major contributor to the occurrence of anemia in children and pregnant women. But when it comes to malaria-associated anemia, we have concepts associated with destruction of red blood cells. We have pitting of the erythrocytes. Is a concept whereby parasitized erythrocytes are able to inject out the parasite, okay, instead of getting hemolyzed, but the area where that has occurred gets pitted, and then the configuration of the erythrocyte changes for a while, and it reduces the lifespan of the erythrocyte down the line. Then we have suppression of erythropoietin, hyperparasitemia at presentation, or direct toxic effect of malaria, being the major contributors or explanation of how anemia occurs in malaria. And just to show us that a starting anemia in the course of treatment tends to result to a persistent anemia. Okay, so here, those who have no anemia, they have an initial fall, and then they recover from the anemia, and we have that progression. Those who start with anemia, yes, they might improve, but you can still see a relatively persistent lower trend, even though they might have recovered from the anemia, but you can still see a lower trend in their own anemia. The black line here is for the entire group combined. So, and when it was compared for different ACTs, artemether lumefantrine, artesunate amodiaquine, and dihydroartemisinin piperaquine, they all behave characteristically in a fairly similar way, though recovery as generated by artesunate amodiaquine was slightly superior to the others. You can see the green line was consistently higher, and then you have the blue and the red line almost together for artemether lumefantrine and dihydroartemisinin piperaquine. So what conclusions do we draw from all of this? Number one is that malaria and anemia represents double jeopardy with the greatest toll on children under 5 years. Malaria contributes to the occurrence of anemia both pre and post treatment. There is a frequent occurrence of early appearing anemia following malaria treatment. Anemia pre-treatment for malaria is a predictor for persistent anemia after treatment. ACTs uniformly improve recovery from anemia, and their use should be sustained in the treatment of uncomplicated malaria in Africa. Severe delayed hemolytic anemia post-injection artesunate is rare in population of under 5 African children with severe malaria. And iron deficiency is an important cause of anemia in African children for which there should be mechanisms for early detection. So what recommendations do we want to make from this? It is to ensure no one is left behind in the deployment of malaria preventive measures. It is an efficient strategy for reducing the burden of malaria, and we also see that it has the double benefit of both malaria and related comorbidities like anemia. There is the need to support wider availability of point-of-care devices to monitor hematocrit or hemoglobin levels in malaria patients. Patients with moderate severe anemia or moderate severe malaria anemia should be followed up, and if the anemia stays within the moderate range and it's persistent. There is need to reinforce messages on the use of ACT for treatment of uncomplicated malaria. They remain efficacious. They have the added benefit of reducing the anemia recovery time. Injection artesunate should remain the unequivocal life-saving treatment of choice in African subjects with severe malaria. And therapeutic efficacy studies should routinely incorporate a study of anemia indices to provide better understanding of the effect of ACT use in our countries. So very quickly, just in some few minutes now, malaria control and COVID-19 response. I just want to show us this, that we said currently we have 228 million cases of malaria reported globally, but this by now will have been 321 million cases if there were no interventions that were in place. So despite population growth and all other things, the interventions being used is contributing to reduction. So you can see the magnitude of that reduction increasing with time. In the same way, mortality is currently 405,000, but without intervention, this mortality will have been more than doubled to getting close to about 1 million cases occurring without intervention. And that sets the tone for us. There are many types of interventions that are necessary for a country that is controlling or seeking to eliminate malaria, including the deployment of vector control measures, special interventions like mass drug administration as mentioned, in this case, seasonal malaria chemo prevention, IPTP for pregnant women, and several cross-cutting activities. Now, what has happened? The COVID challenge has come in, and we recognize the importance of COVID. It is not to be underestimated. It's leading to deaths very rapidly, and hence we need to handle. But the challenges are that enormous resources are required, and there are activities that lead to restrictions of movement. And then the death counts in COVID is more dramatic, it's more visualized, it's more graphic, and it affects personalities that are very prominent. And hence, there is the fear and the panic factor. And this has resulted in various perceptions about COVID. So what has this cost for us? The implication, the effect that we see generally is that of diversion of resources, diversion of attention. The actions that are necessary for COVID and its own implication on the health system. Disruptions in logistics, public perception, health worker perception, sometimes unable to attend to some categories of patients. The summary of all of this being a heavy strain on health systems. The implication for malaria is that there has been a lot of defaults in release of funds for malaria intervention from reports from many countries and states. There's reduced access to healthcare services, people not presenting when they have fever to get tested. There is disruption in commodity supply chain, and there is disruption in planned interventions. The overall impact of this is the threat of reversal of the progress that has been made. Giving an example of Nigeria, this is the kind of progress that has been made with reductions in prevalence of malaria over time based on all the interventions and support of partners and government. And this is showing this trend more graphically from the malaria deaths of this line, from about 200,000 deaths occurring in the country to somewhere around 80,000 deaths. And the number of cases per, mortality per thousand, that has even shown a more dramatic reduction over time. But modeling that has been done has shown that there is the risk of 2 to 3-fold increase in mortality if there is disruption in current interventions. And hence, we want to recommend the following in handling the response to the threat of handling the threat of COVID-19 response on malaria program implementation. Number one, there is the need to appreciate the importance of all killer diseases. No need surviving only to die of another. Hence, the political will for the health systems generally. There is the need to have business continuity plans, finding ways to continue program implementation. In the height of COVID lockdown, Uganda was able to implement IRS in some communities. Currently, they are carrying out house-to-house distribution of net. Nigeria has started its own seasonal malaria chemo prevention in Kano State in northern Nigeria, and several countries are finding different strategies to sustain LLIN distribution. These actions are commendable. We need not abandon these interventions. There's the need to identify synergies and opportunity. There can be co-messaging. Okay, if you have fever, get tested for malaria so that you can know whether it is malaria, or then you can recognize COVID much earlier. So there can be co-messaging, there can be co-testing, there can be improved opportunity for research, health infrastructure, manufacturing, and then building strong surveillance, strategic use of information health system. In conclusion, what we are saying is that COVID, in as much as it requires a lot of resources, it needs not to disrupt malaria intervention and, in fact, other health system intervention. The danger of doing that and the consequences can be enormous, but we can find opportunities, synergies, and utilize this to improve our health system. Thank you very much.
Thank you, sir. I see here that you have elevated my own learning about the specific topic of post-malaria anemia, and I really appreciate for your suggestion and thoughts on the management of malaria in this situation of COVID-19. Thank you again. At this point of time, I would like to thanks. I would like to move to the next topic, and I would like to invite our next panel member, Dr. Annan. Madam is going to talk about another challenge which is commonly faced in the management of malaria and which is very sensitive health concern which is associated with malaria, that is management of malaria during pregnancy. Over to ma'am.
Thank you very much, Dr. Rahul, and hello to everyone watching us on this webinar. Understandably, Okay. All right. Thank you very much, Dr. Rahu, and hello to everyone listening to this webinar. Understandably, I believe COVID has taken a lot of the attention of the healthcare fraternity, so it's a great honor, and I feel very happy that we are discussing another subject of public health importance, such as malaria, more so malaria in pregnancy. Thank you so much for this opportunity. My topic for today is management of malaria in pregnancy in primary care or general practice. So this is my disclaimer. My focus in this presentation is to provide a clinical perspective. This is not an endorsement of the pharmaceutical product that will be discussed in this forum. This will be my outline from the introduction, epidemiology, vulnerable groups. We'll talk about classification,
Hello, ma'am.
complications that, hello.
Sorry to interrupt. Your slides aren't shared, ma'am.
Yeah, sorry about that.
Oh, we need it on slideshow mode, ma'am.
Right.
Yes, ma'am.
So
You can continue.
thank you very much. So my topic is management of malaria in pregnancy in primary care or general practice. And this is the disclaimer. My focus in this presentation is to provide a clinical perspective. This is not an endorsement of the pharmaceutical product that will be discussed in this forum. This is my outline from introductions, a brief epidemiology, some vulnerable groups, classification, etiology, right down to WHO 2015 recommendation for prevention of malaria in pregnancy. Now, malaria is very common infection in Ghana, and the whole of Ghana is at risk of malaria. Malaria in Ghana accounts for 4% of the global burden and 7% of the malaria burden in West Africa. Malaria was responsible for 19% of all recorded deaths in Ghana in 2015. It follows the introduction of the protozoan malaria parasites into the bloodstream by the bite of an infected female Anopheles mosquito. Professor Ghosh took us through the life cycle, so I would not do that here. Malaria is a major cause of significant morbidity and mortality, especially among vulnerable or susceptible groups. Some of these groups include children under 5 years, pregnant women, sickle cell disease, and visiting non-resident Ghanaians and expatriates. They are part of the susceptible groups. Now, the classification of malaria, as per the WHO recommendation in 2015, tells us of 2, uncomplicated and severe malaria. The parasites that may be involved are Plasmodium falciparum, Plasmodium ovale, malaria vivax, and Knowlesi can all be involved in malaria. Now, to malaria in pregnancy itself. Now, pregnancy makes women more likely to get malaria. Generally, people in Africa are more likely to get, but pregnancy reduces your immunity and therefore makes you more likely to get malaria infection. And apart from being more likely to get it, they also are likely to get the severe form of the disease. Pregnancy and complications can arise from malaria infection. The severe form is more likely to occur during pregnancy. Some of the complications include these: anemia, there may be miscarriage, they may end up with preterm labor, or even postpartum hemorrhage can occur. Now, complications to the child may include fetal anemia. What happens is that when the parasite enters into the system, it goes to lodge in the placenta. So we have placenta parasitemia, and sometimes you may not even find them in the peripheral blood, but it's lodging in the placenta, and it causes inflammatory changes leading to placental insufficiency, thereby leading to some of these complications to the fetus, which may include prematurity, intrauterine growth restriction, low birth weight, stillbirth, congenital malaria, and increased perinatal mortality. Now, some of the symptoms which we may want to revise for uncomplicated malaria include fever. There may be a fever. There may be loss of appetite. They may feel chills, rigors. They may sweat, headaches, generalized joints and body pains. There may be nausea and vomiting. And also there may be abdominal pain and diarrhea. Abdominal pain mostly in children. Now, some of the symptoms during severe malaria may include generalized weakness. There may be poor intake, dark or cola-like urine. They may pass very little urine, leading to renal failure. They may have difficulty in breathing, repeated profuse vomiting, repeated generalized convulsions, and then there may also be altered consciousness. Some of the signs we may see when they come to us may include hyperpyrexia, axillary temperatures of greater than 38.5, extreme pallor, severe anemia, HB less than 5. There may be marked jaundice. There may be circulatory collapse, or even some may present with shock. There may be tachypnea, crepitations on chest examination, excessive sweating, oliguria, and then disseminated intravascular coagulation, and there may be also altered consciousness. Now, how do we diagnose malaria? For the diagnosis, you will have to take a history, a very good history. Aside the history on symptoms that the patient may present with, you would also want to know direct questioning. You want to do a systemic inquiry. You may want to do a family history, social history, drug history. And then for us as family physicians and as general practitioners, which will encourage all people to also do, we may also want to hear the patient's perspective of their illness. When we talk about the patient's perspective of this illness, we are talking about a four-pronged question approach. And this, you may want to know, what are the patient's fears about what they are feeling, the symptoms that they brought in with. What are their fears? What are their ideas? What do they think is happening to them and the baby that is unborn? Is it affecting their functioning? What are their expectations from this visit? In fact, this particular perspective of the patient helps you to be able to position yourself well, to counsel the patient and get a very good outcome from the care of the patient. For instance, if your patient thinks her ideas are probably consumption of oily food leading to this malaria, of course, when you give the patient medications, she's not likely to comply to that medication. So you need to find all those things out and then treat the patient as an individual. And that is why, as family physicians, we also do what we call the three-pronged or three-tier diagnosis, where we have the clinical diagnosis, which in this case will be malaria in pregnancy. And then we have the individual diagnosis, which is tailored to the patient. In this case, what the patient answers as their perspective of the illness. So a patient, for instance, fears the death of the fetus because of the malaria and also expects a good outcome from the treatment. So the individual diagnosis may be client fears death of fetus from this pregnancy, but expects a good outcome from your care. Now, we would also like to do the contextual diagnosis, which puts the patient in perspective. Patient with a supportive family, supportive husband, all those things matter in the care of the client. We may also want to use family medicine tools. One of them that is very common that we can use for this is the family circle. And this tells you the emotional relationship around the family, the patient's life. We all know that in the condition of malaria, you are very weak. You need some care, you need some support. So for instance, if the patient's circle shows the husband as being very close in that circle, then the husband may have to take a leave or take some few days off to support this client, to enable your medications to work properly, patients to get well quickly, and then to be sent home. Now, you would also like to do an examination, thorough examination. You would want to examine all systems, and then you would also want to ask about fetal movement, listen with a sonic aid or fetoscope as well. Now, you also then want to do some investigations to certify whether this is really proven malaria or not. Now, I just put this here that summarizes or reiterates what I mentioned earlier as our three-tier diagnosis and looking at the patient's perspective. Sir William Osler, a very famous scientist, mentioned that it is more important to know what sort of a patient has the disease than what sort of disease the patient has. This is very important when treating clients and very helpful. Now, what are some of the investigations that you can do when you suspect malaria in pregnancy? You can do a rapid diagnostic test. There's a single one that detects only Plasmodium falciparum, and there's a multiple one that detects Vivax, malaria, and ovale as well. All these are very sensitive, very good, and very useful in our community in detecting malaria. Now, you can also do microscopy, maybe a thick and a thin film. So the thick film just detects whether there are malaria parasites in the bloodstream or the blood film sample, and the thin detects whether there are, what type of malaria parasites there are, and the count of the parasites specifically. Now, some labs will also be done, other labs will also be done, but that will depend on your history and your examination findings. So, for instance, if you think the patient is pale, you want to do a full blood count. If you think patient is vomiting, you want to do the blood urea, electrolytes, creatinine. If patient is advanced in pregnancy, not feeling fetal movement, you want to do an ultrasound scan. And that will be really patient dependent. Now, our main treatment objective for malaria in pregnancy is to ensure prompt and effective case management of each of the cases that we get. Not forgetting that we would have to take the patient in context. So you need, if the patient has lost fluid, you need to replace fluid. If the patient is vomiting, you need to have IV access, give IV fluid. Patient is pale, you may have to transfuse. All those ones are there. But currently what I'm going to mention are the drug or medications that you can give for malaria in pregnancy. Now, some of the medications for uncomplicated malaria within the first trimester are quinine, oral 10 milligram per kilogram, maximum of 600 milligram 8 hourly. For 7 days, this can be given as monotherapy or plus clindamycin, oral 10 milligram per kg twice a day for 7 days. Like I said, all these recommendations are from WHO 2015, and these can be given as monotherapy or together as a therapy. Now, for medications, for uncomplicated malaria, second and third trimesters, you would want to give artesunate amodiaquine as first line, artemether, lumefantrine, and then quinine orally can also be given for such clients as well. For medications, for severe malaria in all the trimesters and in the puerperium, you can give IV artesunate or IM, then ACT oral for 3 days, or quinine IV or IM, then quinine oral plus your clindamycin combination orally for 7 days. You can also give for treatment of severe malaria for the second and third trimesters and the puerperium, artemether IM, then also after that 3 days of oral ACT therapy. So for prevention of malaria in pregnancy, which is one of the crux or one of the important parts of my practice as a family physician, I would want to prevent the illness rather than getting it and then having to deal with the complications. So for the prevention, we want to use long-lasting insecticide-treated nets. Make sure the weeds around are cut nicely. There are no puddles of water around where you live, the residence. And then also IPTP, which is intermittent preventive treatment in pregnancy. Now, this was instituted by WHO 2015 recommendation, and it comprises of a fixed dose combination of sulfadoxine pyrimethamine, and is given at predetermined intervals after quickening. Now, WHO used to recommend in the 2015 for 4 focused antenatal care visits for normal pregnancy, but now it's actually what we recommend is about 7 interactions with at an antenatal clinic with a care provider, and it's called positive pregnancy experience. That is what we are looking at now from 2016. That was what the publication said. Now, in Ghana, the National Malaria Program, the control program, reserves sulfadoxine pyrimethamine solely for the purpose of IPTP. To prevent drug resistance, it is not used for the treatment of acute attacks of malaria. The dose for the sulfadoxine, 500 milligram pyrimethamine, 25 milligram oral, So the total dose taken by the client are 3 of these. So it will be 1,500 of sulfadoxine and 75 milligram of pyrimethamine. And this is usually done as a directly observed therapy at the antenatal clinic. And this is practiced here in our setting in Ghana for most of the time. Sometimes when you get clients who don't really want to take it, they may ask you for a prescription. So then you take advantage of the situation and then you counsel them on the importance of taking it. And some of them are able to take it right in front of you. Other times too, when there's a shortage, which is quite rare, they may have to be given a prescription to get it and take outside. But each time it must be impressed upon them the importance, the reason for which they are being given these medications. So like we mentioned for the IPTP, first dose after quickening, 16 weeks. So at least 1 month after the first visit, 20 weeks, 24 weeks, 28 weeks, 32, 36, and then 40 weeks. Now, when not to give IPTP? So when during the first trimester, less than 13 weeks gestation, you wouldn't want to give IPTP. G6PD deficient, enzyme deficiency, where there's severe liver disease and unexplained recurrent jaundice, you wouldn't want to give IPTP. When there's a known allergy to any sulfur drug during post-date pregnancy, breastfeeding, or when there's an acute case of malaria, you'd want to actually treat with the recommended medications, anti-malarials that we have previously mentioned. So this is just to reiterate the WHO recommendation for 2015 that mentioned the preventive measures as emphasizing the use of insecticide-treated nets by all pregnant women, and then also intermittent preventive treatment in pregnancy under direct observation. Now also the last point, which is prompt treatment of confirmed cases of malaria in pregnancy. So I would like to thank you all very much for your time. And then I believe we'll hand over to Dr. Rahul for questions and answers. Thank you very much.
Thank you so much, ma'am, for bringing in these very grounded and practical tips in the management of malaria during pregnancy. And one thing I'm learning that basics don't change, and they are always relevant in the management of such cases. So now house is open for the question and answer discussion. And I can see here many questions are getting posted, and most of them they are covered during these all three sessions. Still, I will try to pick some questions which have not been covered during the presentations. And from Dr. Blessing Duru from Nigeria, and I would like Professor Ghosh to attend this question. The question is, why is it that after recovery from malaria, one does not get a lifelong immunity?
See, actually, malaria is a parasitic disease. And in case of immunity, it's called permutation. That means as long as the parasite is inside the body, the immunity is there. So the immunity is very short-lived, and the parasite has got immune evasion mechanism. And the problem is that life cycle is very complicated. They have got different stages of life cycle, and the parasite actually gets mutated very fast, because in the genome, if you see, 82% guanine and cytosine. That means it has very fast mutation process, and then they can evade the human mechanism. And that is the reason that vaccine trials, those who are now doing, you have to be very, very careful. It has to be genome-based vaccines and responses. And there is no parasitic vaccine still now yet.
Okay. Moving on to next question, which is from Pedro from Ghana. And this is related to post-malaria anemia. So I request Professor Mokolu to address this question. Here, Pedro would like to know when exactly to start hematinic therapy in the management of post-malaria anemia, and can these hematinics be given along with any malaria treatment?
So from what you have seen, the primary responsibility is that of having a system to ensure that we also monitor the hematocrit value. Treatments with ACTs in themselves, because they abort the malaria process, we have seen that there is a lot of recovery that does occur. So what you want to watch out for is the persistent anemia, especially after the period of treatment, to see whether there was recovery or not. And the ones that are not recovering towards normal, you now can support with hematinics. You handle them on an individual basis.
Okay, and the next question comes here from Deacons from Kenya, which is for Madam. Ma'am, you have briefly mentioned in your presentation about the allergy to sulfur components in the drug, and the question is related to the same point. What is the anti-malarial drug for the pregnant women who are allergic to sulfur components in drugs?
Okay, so what it is that if you are talking about IPTP, the sulfur doxypyrimethamine is the only one that is used. So for those pregnant women who are allergic to that, you would want to do test and treat. So you'd want to test them if you find out they are positive, and then you treat them.
Okay. Well, I will move to next question now from Dr. Grace from Nigeria, and I think it will go towards Professor Ghosh.
Yes.
How can we overcome the challenges faced by healthcare workers during the implementation of malarial program with respect to monitoring and data collection?
Yes, actually, I think it is in relation to the COVID issue right now, because healthcare workers, they are the frontliners in health system delivery, not only in that particular country, it is everywhere. And I think in this COVID situation, and as we are doing in India, that most of the COVID work is done by the malaria and health workers. So they have to be taken utmost care. And along with that, what Dr. Mokuolu also mentioned, that you have to do the, that side by side, you have to examine for the both. So health, care workers, what you call SCWs, so they have to take utmost care. And because if they fail, if they are infected with this, and also not only COVID, I'm talking of in many countries, healthcare workers, they also get malaria, and they have to be protected from, because there are many methods in doing so. So they have to take utmost care for this thing.
Okay. Well, that brings me to next question from Samuel from Ghana. And I request Professor Mokolu to please answer to this question. What is the treatment of choice for a person with recurrent malaria infection and one with unresponsive treatment with ACTs, quinine, and pyrimethamine?
The first treatment of choice is correct diagnosis. You have to be sure what you are dealing with. Several times, the problem you are going to encounter is a wrong diagnosis. I think I've encountered this question so many times. As we have said, across Africa, sensitivity to ACTs still rank very high, and in most places scoring above 95%. So if you were treating malaria, it's unlikely that you will need several rounds of treatment of ACT in order to effect a cure. So let me make it like this. There is a concept called treatment failure, and there is something called resistance. Treatment failure is failure to achieve your objective of treatment, your endpoint of treatment, irrespective of the cause. Resistance, on the other hand, is a demonstration that you have given the drug in appropriate doses, it is present in the right concentration, and the parasite is persisting. In many cases, what we are talking about is treatment failure, which could start from 1, a wrong diagnosis, 2, wrong utilization of the drug, 3, drug-drug interaction, and such other issues. But to the person who has asked the question, my recommendation is get tested appropriately. And it is not everybody that is an expert microscopist. So we need an expert microscopist, or in the very least, use an RDT, and then have the treatment, and it will go. The person couldn't have been alive just having recurrent malaria every day, unresponsive to everything, and is still okay. So I can assure you that the greatest challenge is wrong diagnosis.
Okay, so you have emphasized here, sir, about the correct diagnosis. What is your opinion about patient education? Because, for example, like artemether lumefantrine, I feel that there is lack of education to the end user about his proper dosing pattern, about its proper uses. Maybe, like, for example, to take it along with uh, oily food. So what is your say on this?
Yeah, so to start with, we were all coming from the era of the use of chloroquine. In that era, chloroquine, because of its antipyretic effect, gave some symptomatic relief, whatever you were treating. But the ACTs have a pure anti-malaria of the effect. You start noticing it as you treat, and in most cases, parasitemia has significantly shrunken in 24 to 36 hours. Okay, so we need to let people know that it's not the way chloroquine works. That's not, in terms of how to have been release meal and all of that, it's not a very practical thing for public health perspective. And it's been tested when people have used it nearly freely. It's still efficacious. So the issue really is to just basically use it in relation to meal. That's all right. And but if the person wants to be specific, augment with a teaspoon without the public that it works. We who are prescribing owe it a duty to complement our prescription with some explanation to the client so that they'll not be disappointed.
Okay, and I can see clock is ticking very fast, and I would like to take one more last question maybe, and this is again goes to Professor Mokolu because this is from Nigeria. Uh, Dr. Oyewande from Nigeria would like to know, most antimalarial drugs are produced in China using their local herbs. Why is Africa not utilizing all the natural herbs in the production of antimalarials?
I think, to the best of my knowledge, there is a lot of search and research for potential candidates that will be useful. What has happened is that there has been claims in excess of realities, and several of them that have been put into the test line have not proven to be as effective. But for instance, take Nigeria. Nigeria has a whole institute that has been established in order to investigate this type of potential compounds that could be taken to become a product. So I think the search is on. Everybody is trying to explore what is in the environment, but it needs to go through the proper scientific documentation process for it to become what it will become. So I don't think we're just without trying to invest in research.
Well, thank you. At the outset, I would like to thank all our eminent panel members for wonderful presentations and giving great clarity on each question. I would also like to thank our audience from different countries for taking out time and attending this online knowledge sharing session. And lastly, but most importantly, I would also like to thank Society of Family Physicians of Ghana, Nigeria Medical Association, and Pharmacy and Poisons Board from Kenya for offering accreditation for this webinar. So all doctors, pharmacists, and all healthcare professionals across Africa, please stay tuned so that you will come to know about forthcoming webinar from Shalina Healthcare. Thank you so much.
Thank you all.